All right. So, congratulations for finishing your cardiothoracic surgery residency and fellowships. And here we are. Uh, Osler course for thoracic surgery. I'll be covering all the congenital. I'll be covering some cardiomyopathy and acute aortic syndromes as well. We'll have plenty of time for questions. If you have questions, please raise your hand. It's important to have this as an interactive talk, and we have plenty of time, even though it's many hours. So before we get started, just as an outline of the thoracic portion of this talk. So these are the topics we're going to be covering. It's a lot of different congenital lesions. We'll talk about some congenital lung at the end, and then we'll do the cardiomyopathy. I think you've had a heart transplant talk already, so that is in line with the heart transplant talk. And then we'll do the acute aortic syndromes, mostly aortic dissection, but the ulcers and the intramural hematoma. All right, so for the boards, for each lesion, you really need to know sort of the basic outline as shown here. You need to know the anatomy. What is it? What's a complete atrioventricular canal defect? What are the components of it, for instance? What's the pathophysiology? How does the blood flow affect the lesion? What happens to the blood flow coming from the systemic circulation? How does it interact with the pulmonary blood flow? What's the clinical presentation? Some patients are asymptomatic. Some patients present early. Some patients present very, very early in the first week of life. So it's important to have a rough idea of how they present. What's the appropriate diagnostic workup for these patients? Mostly of that's going to be, everybody gets an echo, right? It's a non-invasive test. Everybody gets an echo. Some patients will get a cath, not everybody. Some patients will get some other studies like CT or MR. For the boards, everybody gets an echo. Of course, you need some blood work, some EKG, but that's really for the oral boards later on. What are the indications for surgery? When do you operate on these patients? So you have an ASD. Are you going to operate on the first week of life, or how about a VSD, or how about a transposition? So you have to know what are the indications for surgery, and then when would you do the surgery? For the written boards, you need to know some things about the surgical management. How do you do the operation, but not in great detail. That will be covered later when you get to the oral boards. And then you need to have a basic idea of some of the more common post-operative complications for these lesions. So junctional ectopic tachycardia for tetralogy, for instance, complete atrioventricular heart block for VSD closure, and so on. All right, here are some of the tips. Just know the basic lesions and presentations, know the basic management of the workup, recognize some of the lesions by chest x-ray, like a boot-shaped heart or a heart on a string for tetralogy and for transposition, respectively. Look at some of the cath images. A lot of them are going to be very straightforward, and we'll cover some of those here. Again, pitfalls, complications, CSATs is important. There are also board review course books as well that are out there. So let's just talk, we'll just start with a couple of questions, just general questions. So what percentage of myocardial blood flow occurs during diastole? And of course, I don't expect you to answer these because it's hard to be interactive in the setting, but think about it here for a few seconds. What percentage of myocardial blood flow occurring during diastole? So the question is really, is most of the myocardial blood flow occurring in systole or in diastole? And I got an answer saying D, and let's see what the answer is. It is D, in fact. So 80% of the blood flow is in diastole. So that's why if you look at the single ventricle trials and you have patients that have, say, a BT shunt, a blay-lactosic shunt versus a patient with a SANO, right ventricle to pulmonary artery conduit, the BT shunt patients have a lower diastolic blood pressure compared to an RVTPA SANO conduit for pulmonary blood flow in the setting of a single ventricle. So as a result, you have lower blood flow. You have runoff into the lungs in diastole with a BT shunt. You have less myocardial blood flow, if you will, in diastole because you have a lower perfusing pressure compared to the SANO RVTPA conduit, and that's why we think it's a bit more helpful in the early post-operative period after a Norwood. What statement regarding the aorta and aortic arch is correct? So we have 5 statements here. We'll read them together. The aortic isthmus lies proximal to the left subclavian artery. So you have to figure out which one is true. Is that true or false? The most common aortic arch anomaly is a right aortic arch with aberrant left subclavian artery. So that's a version of a vascular ring. Is that the most common aortic arch anomaly? The ascending aorta arises posterior and to the right of the pulmonary artery. So anatomically, how does the ascending aorta arise within the heart normally? A double aortic arch is the most common type of vascular ring. So double aortic arch is where you have 2 aortic arches surrounding the trachea and esophagus. Is that the most common vascular ring? And we have an interrupted aortic arch is usually associated with truncus arteriosus. And we have answer C, and let's see if it's correct.